case who had come to me. Now, this is a 70-year-old male patient. If you see, his deformity is quite bad, but the complaints he had was of bilateral leg pain, which was claudicant type. So, and the alpha S1 or the last segment of the spine was having listhesis. So, as per the clinical diagnosis, his symptoms were due to the listhesis and lumbar canal stenosis at the last segment of the spine. So, you need not go and correct the entire deformity of. Can we see that X-ray? Can people see this X-ray? Because for me, it is behind the list of the participants. Prerak?
Yes, sir. Oh, sir, ekdam perfectly.
Yeah, people can see the X-ray on the right-hand side of the screen.
Yes, sir. Yes, sir.
Yeah. So if you see that X-ray, that's how his whole spine looked like. And basically, it was a well-balanced spine. So we don't see just at the shape of the spine in the lumbar level, but you have to look at the entire spine. And the lumbar curvature is well balanced by a thoracic and upper thoracic curvature. So the entire spine is deformed, but if you see the line which I have drawn, the entire spine is sort of balanced. There is a slight imbalance coronally. Otherwise, the whole spine is balanced. So I didn't go for the entire spinal deformity correction, which would have been a huge job. The patient was 70 plus years of age, and his main problem was clinically related to the lower lumbar spine. So I just decided to do a decompression and fixation of the lower lumbar spine. Now, I think he is almost 2 years after the surgery. He is ambulant very comfortably, doing all his jobs. All his pain in the legs has disappeared, and he lives with this deformity. So you need not correct all deformities that come to you. Now, this is a very interesting case of a very bad deformity in the neck. There is a patient of something known as the Larson's syndrome. You can look it up. It's a syndrome involving multiple skeletal deformities along with spine involvement, where they have kyphosis of the cervical spine, which goes on progressing. If he had come at the earlier stage, the plan would have been just a posterior fusion where you stop the growth from the back and then the spine grows straight, because there is an imbalance in the growth in these patients wherein the anterior part of spine grows more and the posterior spine the posterior part grows more and the anterior part doesn't grow as much. So what we do is just fuse the spine posteriorly, and that restores the normal growth of the spine. But this was a 9-year-old boy who came to us with this deformity. We suggested him surgery to correct the cervical kyphosis. And this was his X-ray in December 2017, which was not as bad. And while we prepared for the surgery, it further worsened. And you can see the part of bone which is projecting into the spinal canal. He was unable to walk, all symptoms of myelopathy. He had bladder bowel involvement and almost grade 1 to grade 0 power in his lower limbs. Now, this is a very challenging case to operate, especially kyphosis are much more difficult than scoliosis. And one of the issues, if you see a transverse line at the level of the chin, the deformity is present above the level of the chin. So an approach to the deformity, we usually go through the anterior approach in the neck, but to approach this spine which was above the level of the chin was extremely difficult. We would have required a special approach by resecting the mandible and all. But then what I did was, see, this is the problem. So his deformity was above the level of the mandible or the chin. So now we decided to give him some traction to sort of pull his neck and correct the deformity a bit so as to get the deformity part into the neck. So when they come into the neck, I can do a simple anterior approach for the neck. We applied around 5 kg of traction in gradually increasing amount over a period of 10 to 15 days. and his deformity sort of corrected a bit. You can see the pre-traction view and a post-traction, where the deformity part did come down into the neck and it corrected a bit. It made job much easier for us. Now we made a 3D model of the spine for him to understand the deformity better. We applied intraoperative traction so that the deformity remains corrected. And this is the positioning, all the wires attached to the patient, they are all for the neuro monitoring, wherein we see real time that how the changes in his spinal cord are happening, so that if there is any pressure on the cord during the surgery, we immediately stop and do the necessary modifications. So this was the deformity, and then intraoperatively you could see it is well below the level of chin, and that's how we removed the entire part of the bone which was pressing on the spine, and we used a fibular bone graft along with a plate applied anteriorly. So that was the anterior approach and correction of deformity. Post-operatively, the patient dramatically improved. We did a post-op MRI and CT scan, and you can clearly see that the spinal cord is now very much visible. All the pressure on the spinal cord is gone. He started improving neurologically. Now the issue was a standalone anterior fixation with just two screws in C2 and two in C6 may not hold. That was our worry. So we decided to do another posterior surgery wherein we put in posterior pedicle screws as an additional support and did a fusion posteriorly as well. So we corrected the deformity, removed the pressure on the spine, and fixed the spine. Post-operatively at 3 months, he was able to stand and walk. Was a very rewarding surgery, but a very difficult one. He was able to, at 1 year, he was able to walk on his own, do all movements, stand on one leg. And this was the post-op X-ray at 1 year, where you see that the fibula has almost united with the spine, and it is a good fused spine. He was doing very well. So this year, April was his 2-year follow-up, but unfortunately, due to the lockdown, he is unable to come. Otherwise, we could have had his recent X-rays. Now, then coming to the part of arthritis, it's mostly a job of a physiotherapist, then a physician who will look after the arthritis, control the arthritis, and then if there is some deformity which develops like in Angst-Pond or rheumatoid arthritis, then we come into play where we can correct the deformity, do a decompression or as required. Now, arthritis predominantly we have these two common arthritis. One is ankylosing spondylitis and other is rheumatoid arthritis. Angst-Pond is generally seen in a young male patient around 30 years of age, 20, 30 years of age. He will complain of morning stiffness, which gets better with activity. The pain will be to begin with at the sacroiliac joint, which may then progress up the lumbar spine into the thoracic spine. They may have pain while taking deep breaths because the costosternal joints are all involved. Then if you do CBC, ESR, CRP, they will be all raised ESR, CRP because of the high disease activity. And if you do a HLA-B27, it will be positive in these patients in 90% of cases. So Angst-Pond is diagnosed by HLA-B27 and the clinical symptoms. Now the problem with these patients, as you all might have known, that they tend to develop a kyphosis of the spine. They keep on bending forward as time progresses if the disease activity is not controlled. So that's where the role of a physiotherapist comes in. And we recommend very aggressive physiotherapy for them in the form of extension exercises. We want them to remain as straight as possible, because if they go into kyphosis, they tend to go down, down, and then they are even unable to look forward while walking. And these are extremely difficult surgeries to be done. When there is a good amount of kyphosis, it involves some very complicated osteotomies and correction of deformities with very high risk of paralysis. So it's better to avoid those deformities than to try and correct them. For any spine surgeon anywhere in the world, these are extremely difficult surgeries to be done. Correction of deformity in ankylosing spondylitis is a very difficult surgery. So the role of physiotherapist is crucial in these patients. You have to keep them straight. The pain and the inflammation part is taken care by the physician or the surgeon, where we can give them anti-inflammatory medicines, anti-rheumatoid, anti-arthritic medicines, which can control the inflammation. And physiotherapy will help keep the spine sort of mobile and straight as much as possible. Even if the whole spine fuses, you might know that Angst-Pond is a condition where the joints fuse, especially the spine. So even if the spine fuses, we are happy to have a straight immobile spine than a kyphotic immobile spine. So the role of extension exercises is very crucial in these patients. Now, coming to rheumatoid arthritis, they might have back pain, neck pain, which can be serious because C1, C2 is usually involved. Typically, these patients have deformities of the hands. They present with small joint involvement, as against Angst-Pond, which presents with spine and large joint involvement, like the hips and the shoulders are involved. So, rheumatoid arthritis, if you look at their hands, feet, you can see the inflamed, swollen joints. The wrists will be deformed, the fingers will be deformed, and that's how you can diagnose with the RA test and ESR CRP levels. And again, medical management is crucial. And if a patient presents with neck pain, we usually advise MRIs, X-rays to look at the status of the C1, C2, because C1, C2 joint tends to dislocate or subluxate in these patients very easily. So this is one of the cases I had last year. Was a young lady with sudden onset pain in the neck. You see her whole of the spine is fused. A rare case of female having ankylosing spondylitis, very quite rare. Involvement is 3:1. If there are three males, one female can be involved. So that's how uncommon it is in females. So this lady, if you can see the MRI, there is a bright, like a white shadow seen at the 2, 3, 6, 7 level. So that's where she had developed a fracture of the spine. We call this lesion as the Anderson's lesion, where if a fracture develops at one of the places, it does not heal. There is fluid accumulation there. It will keep moving because this fracture is like a long bone fracture. In spine, in a normal spine, if one of the bone fractures, there are multiple levels of the spine where there is movement. So the movement in the spine is distributed across multiple levels. But in these Angst-Pond patients, if the whole of the spine is fused, there is no movement anywhere in the spine. So if one of the level fractures, it's like a fracture of shaft femur, which will never unite because it's a fracture at one level and the rest of the spine is like a long bone. So this has to be operated. There is no conservative treatment for a fracture of the spine in ankylosing spondylitis. Okay, because these fractures never unite, they become unstable, and then they cause neurodeficit. So this lady had a facetal dislocation at C6-7, and she had a non-union anteriorly, and the neurology was normal. So it becomes a very challenging case for me when the patient does not have any neurodeficit and I have to correct the deformity and fix the spine. Suppose the patient has a quadriplegia, I have all the excuses that even if I injure the nerve was already injured and the deficit was already there. Now in this patient, if there is any intraoperative nerve injury, it is not forgiving because the patient preoperatively did not have any deficit. So I have to be extremely careful when I do this surgery. And this requires a long fixation. Like in shaft femur, you might have those who might have seen plating of shaft femur done in olden days. We used to fix at least four screws above and four screws below. So similarly for spine, this is like a long bone fracture. So we require four level fixation above and four level below, 3 to 4 level below to achieve a good fixation for the fracture to unite. So this was at the cervicothoracic junction, which is a very high stress area. I did a fixation